On behalf of Brazilian Society of Functional Neurosurgery, I'd like to thank everybody for their attendance in our webinar. The audience has reached a peak of about 250 attendees every week, and lectures have been great. Today, our topic is surgery for epilepsy, and Dr. Paulo will present the speaker and panelists. Thank you. Go, Paulo.
Thank you, Professor Antonio. Welcome, everyone. Intractable epilepsy is a major health problem resulting in cognitive and psychological impairment and diminished quality of life. Surgery is a safe and well-accepted treatment option with proven better results than drug treatment for intractable epilepsy. Today, our panelists are teachers, all of them doctors in surgical treatment of epilepsy. Professor Hélio Machado is a full professor of the Department of Surgery Anatomy, Ribeirão Preto, Universidade de São Paulo, Brazil. Professor Estênio Sarmento is a coordinator of Epilepsy Surgery Service, Hospital Municipal Santa Isabel, João Pessoa, Brazil. Professor Eliseu Paglioli Neto is a head of Neurosurgery, Hospital São Lucas, Universidade Católica do Rio Grande do Sul, Brazil. About our topic, I must say that Rolandic epilepsy surgery should be considered an impossible mission. But there are people like Professor Jorge Martinez. He is a director of the Department of Neurological Surgery, Epilepsy and Movement Disorder, co-director of the Epilepsy Center and Cortical System Laboratory at the University of Pittsburgh, USA. Pioneer in the new surgical methods for treatment of refractory surgery, such as stereoelectroencephalography, SEEG guide laser ablative procedures, neuromodulatory interventions, and robotic surgeries, bringing innovative surgical interventions to the United States and other countries for the first time. His field of particular interest is neuroelectrophysiology, being known by many as a neurophysiologist and by others as a neurosurgeon. For me, a great friend. Professor Jorge Gonzalez Martinez, the stage is yours, please.
Okay, thanks so much, Paulo. Let me share my slides here. I'm gonna go here, couple minutes. We have, I believe it's this one, share. Go here. Excellent. Everybody can see my slides?
Yes. Okay, it's good.
Very good. I would like to thank first the Brazilian Society of Functional Neurosurgery for this very kind invitation. It's such a pleasure to talk with my friends and colleagues from Brazil, the place that I was trained. I'd like to thank you, Paulo, Estênio, Hélio, Antonio, Eliseu, and the other members of the society for this kind invitation. Thank you so much. They asked me to talk about Rolandic epilepsy. And I believe we have perhaps 30 minutes, 40 minutes. We will introduce the topic. And we are going to talk about some examples and how we manage those very difficult cases, probably one of the most difficult cases in epilepsy. So I just want to disclose my conflicts. I don't think they are necessarily relevant to this talk. The first thing that I would like to talk about epilepsy, Rolandic epilepsy, those are challenging cases. There are no question about. They are probably one of the most challenging cases we do, as I said, in epilepsy surgery. It's a procedure that carries very high morbidity and many times a high failure rate. The surgeon is always concerned about resecting Rolandic cortex. And the chances for what we call a double loser is very high. And what is a double loser in epilepsy surgery? A double loser in epilepsy surgery is a patient who fails epilepsy, who continues to have seizures, and will have now a neurological deficit that is iatrogenic due to the resection of those areas. So the rate or the chances for this patient to become a double roser in Rolandic epilepsy are very high in general. And that's why surgical procedures are so difficult. In general, those patients, they require some sort of invasive monitoring to guide the resection in a better, safe, and efficient way. And when we talk about invasive monitoring, we can have the options of intraoperative or extraoperative invasive monitoring. And I believe each center, different centers, they have different experience and they have different success rates and are more used to one technique versus the other. So again, there is no right or wrong. I'm just going to expose the way we do or we approach those procedures in our center, but definitely there are other centers that will approach this in a very different way. And the last topic, the last point I would like to mention is that in many centers, there is those procedures are contraindicated. And depending on the seizure burden that those patients have and the frequency and severity of seizures, perhaps those patients are not considered candidates for epilepsy surgery. So it's important here to have a very clear, informed consent to explain to the patient that those procedures are difficult, they carry a high morbidity rate, and there are no guarantees for seizure freedom. So it's important to really clarify that those procedures are very, very difficult. I would like to start with a typical case in previous operated. This is a 3-year-old child with epilepsia partialis continua on the right hand. And as you can see here, this is what we have here on the top left is a sagittal MRI T1 that shows a possible lesion located in this area here. Most likely, this is a cortical dysplasia or a balloon cell cortical dysplasia or a type 2 cortical dysplasia or a neurodevelopmental tumor or a combination of both, which is common. Definitely the lesion is probably associated with what we call the epileptogenic zone, but not necessarily the entire epileptogenic zone is located within the lesion. This is one question, one point that needs to be clarified before we do any resection. The other point is that this lesion is clearly located in the Rolandic region, and most likely this is the area where probably the Rolandic motor cortex is located, and this is probably the post-central gyrus, perhaps the sensory cortex. And what we see here is a lesion that perhaps is coming precisely from the central sulcus. And if you see here, probably coming from the banks of the sensory cortex at the depths of the central sulcus. So in order to understand what is the extent of the epileptogenic zone, and in order also to define the functional cortical areas, this patient underwent an invasive monitoring, an extraoperative invasive monitoring method, which was a subdural grid implantation. As you can see here, this is a craniotomy performed, and you can see here most likely the location of this lesion. It's a pale lesion that is probably between the pre-central gyrus and the post-central gyrus, just located probably in the proximities with the central sulcus. Probably this was a cortical dysplasia that originally was originated from the central sulcus, most likely more from the sensory because of the MRI features. So what we did was the craniotomy, and we implant and what the subdural grid, and this is the co-registration between the lesion, the Rolandic areas with the motor and the sensory most likely, and the location of the subdural grids. And here are the results of the extraoperative mapping that we obtain for this patient. You can see here in blue and turquoise the location of the lesion. In red is the location of the hand motor area located on the rostral and superior aspect of this lesion. In green is the location of the sensory cortex. And the ictal onset that we record was within the lesion in this contact, but also outside the lesion. So as you can see here, what we defined to be the epileptogenic zone, at least for subdural standards, is the lesion itself, portions of the lesion, but also areas that are outside the lesion, in this case, located in the sensory cortex. So what we did was exactly what the subdural demonstrate to us. This is the post-op resection intra-op, showing the preservation of the motor strip, the preservation of the central sulcus, the resection of the lesion, and also the resections of portions of the sensory cortex here, as you can see. The pathology showed a cortical dysplasia type of balloon cell in this location in the lesion, and also some mild forms of cortical dysplasia in the sensory. So this patient became seizure-free and with an initial neurological deficit, which recover most likely because of the age and also because of the resection, a small resection in the sensory cortex. So I think this case clearly illustrates the value of extraoperative invasive monitoring in managing those difficult cases, not only to define what we call the origin of the seizures and the epileptogenic zone, but also to provide a very clear demarcation and very clear interface between what is considered to be functional and what is considered to be the epileptogenic zone. The subdural grid, because of his high density superficial location of the electrodes, it became in many centers as one of the most important methods of extraoperative monitoring in MAP for functional mapping. The problem with subdural grids many times is that it does require a big craniotomies, and the big craniotomies many times come with complications. In many centers, subdural grid operations are probably the most morbid procedures that we have in epilepsy surgery, many times carrying a 20 to 25 complication rate. So that's a problem. The other problem also is that the subdural grids can only record from the surface of the human cortex. And there is a completely targeting of the depths of the cortex, for example, the depths of the sulcus and other difficult areas, specifically in the Rolandic cortex. And when we record from the surface, what we see many times is a large spread area, which will force the surgeon or mislead the surgeon to perform a large resection or to contraindicate surgery, because the areas that are involved, the seizures involve precisely the entire Rolandic cortex. That was the reason why we started approaching those cases using depth electrodes. And again, there are many ways to perform those operations. I'm just disclosing to you what our experience with those cases are. And right now we approach Rolandic epilepsy mainly with a combination of intra-operative monitoring and also extraoperative monitoring with SEG electrodes. And I will show you in a second a couple of examples how we do that. So this is just an example of a temporal occipital implantation with DEPS electrodes. An SEG implantation, as you can see, is a less invasive percutaneous implantation of DEPS electrodes guided by a very precise implantation hypothesis. This is not a new technique. It was being around for many years, developed initially in France in the 1950s. And with some previous work from the founders of this methodology, And this is a good example of the very classic atlas of Talerac and Zikla. We can clearly define from a stereotaxic aspect the locations of the Rolandic cortex that will help us to really precisely implant the electrodes in this location. So with this method, the stereotactic system developed by Talerac and colleagues, you can see here, this is the classic AC and PC, the projection of the AC-PC in the lateral neocortex. And what we can see clearly is that, for example, what we call the Rolandic line, which is the location of the central sulcus, always will start behind the vertical AC, which is the vertical line that comes from PC, and will always finish behind the vertical line going through PC, so VPC. So this is a very constant topography, and clearly identify and clearly help us to really define the Rolandic areas in epilepsy surgery using the stereotactic methodology. Of course, after the after the overcoming of the MRI, this becomes a little bit obsolete, but it's still a very good way of defining where the Rolandic areas are located. The same way the pre-central sulcus are also always located in front of the AC, and also the post-central sulcus will always be located behind VPC. So based on ACPC line, you can clearly define the different subunits of the motor cortex that will guide us for the implantation of Rolandic epilepsy. The implantations are performed in very different ways. Now talking about technique, this is the standard stereotactic Lexel frame, which is very precise, but quite frankly, cumbersome in many ways, specifically when you need to implant 10 to 15 electrodes. It becomes a difficult, more workload operation. And we have the luxury in our institution to use robotic devices, which has the same precision as the Lexel frame or stereotactic frames, but with the advantage of the speed and efficiency in the OR. And this is one of the intraop X-rays showing the diffuse bilateral implantation of depth electrodes guided by a very precise hypothesis, which is the SEG method. So this is an example of one of our early examples of patients with a Rolandic epilepsy. This patient had I don't have a video, but had a very clear semiology showing eye contraction on the contralateral side, followed by versive contralateral versive of the head, and also the neck to the contralateral side to the left side. And here we can see on the MRI perhaps a very clear hypersignal flare that may suggest the occurrence of a cortical dysplasia, perhaps a cortical dysplasia 2. This patient was completely medically refractory, so we took him and we implanted him with depth electrodes. And this is the co-localization of the co-restriction of the depth electrodes in relation to his anatomy. And the dots, they represent the entry point of the electrodes, and those electrodes are implanted in orthogonal fashion. So you need to understand those electrodes, they go all the way to midline. So here in blue is the location of the lesion. And here is the mapping of the implantation in the motor cortex age in the hand area that will finish in the posterior SMA, and the L in the lesion, also R in the face motor, and around the peri-Rolandic cortex. So what we saw here was, and again, this patient had on surface a very diffuse onset that involved the whole frontal central region, so a large area. But as you can see here, with the depth electrodes, you can clearly narrow down the areas responsible for the organization of seizures in this area precisely at the center of this lesion. And you can see here the organization of the seizures with the repetitive spikes, and those are transition towards high frequency and absence of low frequencies. And then you can see the organization of those activities, and this correlates with his clinical semiology. So the conclusion of our map is that the onset was located in the lesion with a very fast spread to the motor and the frontal, and then late spreads to the entire Rolandic areas. But what perhaps I would like to emphasize is that the type of functional mapping that we can obtain in those type of implantations. With subdural grids, again, it's a very nice definition of the surface of the superficial cortical areas. But when you have a deep area, when you have a deep sulcus cortical dysplasia, many times what your interest is on the mapping of the white matter that surrounds the lesion, and not so much on the surface. Of course, you're interested in the surface, but mostly also in the white matter. So this is to illustrate that this is the trajectory of the electrodes with all the contacts and how precise you can have, how many information or the amount of information that those depth electrodes can provide just because you're mapping the white matter in this location. In this picture, you can see here the mapping of the L electrode. And here we see the mapping of the F electrode, clearly showing the frontal eye fields and the locations of the motor areas. Now the locations of the sensory areas. So in resume, this is the type of mapping that you can obtain, a very broad, detailed mapping, not only from the surface, but also from the white matter. This type of information can only be obtained in the extraoperative scenario using depth electrodes. The subdural grid will not give you any information of mapping in areas in the subcortical areas. Because of that, and because of the precision of the implantation, we can many times perform small resections guided by the SEG recordings with very optimal surgical outcomes, clinical outcomes in terms of deficits. So this is a patient that had a Rolandic epilepsy, completely a non-lesional MRI with a PET scan that shows some clearly hypometabolism located in the Rolandic areas. This patient underwent an SEG evaluation, and we performed a very focal resection just in the posterior SMA and portions of the motor. She developed a deficit, a foot drop, who recovered very well after post-op day 1 and 2 with the rehabilitation. So she's doing very well. So again, this is to illustrate how we can operate it guided by depth electrodes used in very high eloquent area, which was a notion that was not clearly accepted in the past. But perhaps we need to revise a little bit the anatomical landmarks in the how to perform functional mapping and how we can apply the notion of the anatomical regions and explore those areas with depth electrodes. In order to do that, we really need to define where to put the electrodes. So the functional mapping many times in SEG starts before the implantation of the depth electrodes. You need to have a previous knowledge. Where do you believe the functional areas are located? So from a stereotactic front of view and from a didactic aspect, I am presenting here specimen, an anatomical specimen. And of course, this is the midline. We're talking about the mesial aspect of the hemisphere. And this was injected with red in the arteries and blue in the veins, very consistent. And I just want to emphasize this is what we consider to be the AC, and this is what we consider to be the PC. And once we define that, we have the ACPC plane, and then finally the VAC and VPC. So based on those stereotactic coordinates or reference lines, we can define the very different areas in association with the motor cortex and with the perirolandic areas. So here, behind VPC, you can have the leg sensory and the leg motor areas. between the VPC and VPC, you always will have the SMA areas in the midline. And in front of VPC, you will have the pre-SMA areas related many times with language function. Between VAC and VPC at the cingulate level, that's where we're going to find the central cingulate, or many times also referred as the motor cingulate, an area in the cingulate that can provide motor semiology that many times can be confused with Rolandic epilepsy, and many times guiding the wrong operations. And behind the VPC, of course, the posterior cingulate, and anterior to VPC is the posterior cingulate. So if we represent how we implant those electrodes, and again, we always will implant electrodes in a very systematic way, in orthogonal way, we can explore the implantation or the Rolandic areas with orthogonal electrodes, with the 2 electrodes in the sensory leg and the motor leg, 2 electrodes in the SMA, posterior SMA and anterior SMA, 1 electrode in the pre-SMA, and electrodes in the posterior, central, and anterior cingulate. We need to also to understand this is a 3-dimensional aspect. So the target in SEG is not only the end point of the electrode, but the entire trajectory. So we need to understand those mesial aspects, mesial functional areas, what is the relation with the lateral neocortex, so we can understand. So here again, we're going to repeat, this is the dorsolateral aspect of the hemisphere. This is the projection of the AC, the projection of PC, AC-PC plane, VAC, and VPC. And again, we have the same units, the posterior Rolandic leg sensory areas on the mesial aspect. This is just the projection to the mesial, the SMA, and the pre-SMA, and of course, the location of the cingulate. So we have the same electrodes that we show in the previous slide. And on those electrodes, again, on the mesial aspect, the last electrode will map the sensory leg area. The mesial aspect of this contact will map the motor leg, which is posterior to VPC. And then we have the posterior SMA, the anterior SMA, and finally the pre-SMA. And the lateral context of the sensory leg area will map the associated parietal areas. The lateral context of the motor leg will map the hand sensory areas. The lateral context of the posterior SMA electrode will map the hand motor areas. The anterior SMA areas on mesial will map more laterally the frontal eye fields. And the motor cingulate on the lateral aspect will map the central sulcus. So based on ACPC coordinates and a very simple anatomical distribution, you can clearly define the very fine and several units in the motor and perimotor areas and sensory areas that will provide you some guidance for its functional mapping. So the reason why sometimes this confuses is because the motor system is in oblique fashion, and I'll explain this in a more systematic way. This is a representation of the patient's head. Here is the rostrum. This is the back. This is one ear. This is the representation of the ear. So here we have the VAC, which is anterior to the ear, always. The VPC, which is posterior to the ear. And as I told you, the central sulcus will be located between the VAC and VPC. The precentral will be located anterior to VAC, and we finish posterior to VAC, and the same for VPC, for the postcentral, which will start at the VPC and we finish posterior. So how this works? So if we implant orthogonal electrodes, you can see this electrode, the electrode that will map the hand motor area on the most lateral aspect will cross the precentral sulcus and will map the posterior SMA on the more distal aspect. The electrode that will map the sensory hand area on the lateral aspect will map the motor leg areas on the mesial aspect. And again, the electrodes that will map the associated part map finally the leg sensory area. So it's important to understand that when you perform the functional mapping in Rolandic epilepsy, this organization is very common, and it will be important to understand before implanting the electrodes, where do we believe those areas are located in order for you to have optimal functional mapping. So how this is applied for patients? So this is a 3-year-old kid with, as you can see here, this very clear clonic movement on his left hand. This is this kid has around 100 to 200 events like this every day, sometimes associated with generalized tonic-clonic seizures, completely refractory to medication. And definitely the mom is concerned. She noticed some delays in his neurodevelopmental stages. So quite a severe and worrisome epilepsy. Unfortunately, his MRI is normal, was reviewed by several neuroradiologists in our institution. The PET scan revealed perhaps some hypermetabolism over here on the right side in the location of the Rolandic cortex, which will fit quite well with his semiology. The suspicious here is this kid has Rolandic epilepsy, most likely coming from areas of high eloquency, with an scalp BG, very diffuse central and frontal, with a non-lesional MRI. Very hard situation for this kid. We perform a MAG scan that shows some very clear clustering located again in the same location that the PET shows some hypometabolism over there. So again, the hypothesis for this child was this probably is Rolandic epilepsy. It would be very, very difficult to perform any type of extra or intraoperative mapping for this child. And we decide again to perform an stereotactic exploration. And here you can see the intraop MRI showing the position of orthogonal electrodes. As I showed you before, those are the electrodes located in the SMA, anterior SMA, posterior SMA, the hand electrode, the sensory electrode, the parietal electrodes, and again, the cingulate electrodes. And again, this is just the reconstruction of the electrodes showing the anatomical relations with those electrodes. So this is the recording that we obtained in the extraoperative and the EMU, showing very focal activity coming from electrode age, which was exactly the electrode that we had the suspicions that was the Rolandic hand motor. When we perform functional mapping, we clearly localize the hand motor areas exactly in this location, which confirm, unfortunately, our hypothesis that this was perhaps a motor cortex epilepsy, which will carry a high morbidity. So it's important to understand that every time we are implanting electrodes, we are blindsided by the location of the electrodes. And there is always a possibility that seizures are perhaps spreading to the electrode, but we just don't realize. And it's just the first electrode who pick up the activity is exactly that one. So we have two hypotheses for this kid. Hypothesis number one, which was most likely for us, is that the epileptogenic zone was located in the primary motor area. And in order for this child to become seizure-free, a resection of the hand motor will be necessary, which will cause a permanent deficit. However, the hypothesis number two is that perhaps the epileptogenic zone was spreading very fast to the motor cortex, and we just first localized in by the electrode located in the hand area. And perhaps there were areas that we didn't have electrodes, and perhaps in the sensory or in the depths of the central sulcus that we didn't record. And when you pay attention to his semiology, you see that the first sign this kid does is he looks at the hand without any movement, which may give us the impression that perhaps this is sensory in origin and not motor. So I just want to repeat this for you so you can take a look.
Right, I can go get it. There's one right here.
Very good.
Nope.
I hope you realize how he turns the hand without any movement before he started having the clonic. So he feels something in the hand, and after that, he started having clonic. So in order to sort this out, the only way to do is a combination of methods. Perhaps we could do this resection with intra-op recordings of SEG electrodes, and we could do a stage resection. Perhaps we could take this patient to the OR and do a resection while we're performing the SEG recordings in the OR. And we go from the less eloquent to the more eloquent areas, from the sensory to the motor. And we keep checking stage by stage if the epileptogenic zone vanishes or not. And this is what we did. So this is the location of the electrode. Our plan of implantation is, or the resection was to take this patient back to the operating room and perform a stage resection. The first will be the sensory cortex. We will do the resection of the sensory cortex, arrest our activity, our resection, record the activity, and see if the activity continues. If the activity continues, we will perform then a stage 2, which now extend the resection towards the sensory. Towards the central sulcus. And if this activity continues, finally, to extend the resection to the motor cortex. So we took this kid back to the OR. We used the bolts of the SEG as fiducials, which will give us very precise localization of the electrodes. This kid was under general anesthesia. We connect the wires to our EEG machine, and we wait perhaps for half an hour until we have a very good recordings from the SEG, which was very similar to what we obtained in the extraoperative EMU areas. Because we implant electrodes in orthogonal, we know exactly where the electrodes are located. This is the plan of the resection of the craniotomy. Here is the craniotomy that we perform. You can see here the exposure of some of the anterior electrodes. This is a parisagittal. This is exposure of the cortex. And finally, the exposure of some of the bolts where the electrodes are located. As you can see, you cannot see any electrodes because there are depths into the depths of the Rolandic cortex. We perform extraoperative, SSCPs to localize the central sulcus. We obtain nice inverse potentials over there. And this is location of the central sulcus by intra-op physiology. This is the pre-motor or pre-central gyrus, the post-central gyrus. And again, this is the recording that we obtain activity very broad in the age, but also in the cingulate. We plan our stage 1 resection. This is the central sulcus, and the first will be the resection of portions of the sensory cortex, as I told you. This is the projection of the electrodes at the depths. This is the M electrode, which was not involved. This is the S electrode, which was not involved. And finally, the H electrode that was involved. The most of the activity was located over here in the motor, but we decided again to do the resection in the sensory areas. We start performing the superior resection with removal of the sensory cortex in that location. You can see here the exposure of the sensory cortex, of the PO of the central sulcus, and finally the initial exposure of the H electrode. And this is the final spectrum with the resection of the sensory cortex with preservation of this central pia and also the motor. And then we arrest and we perform the recordings. If the activity continues, we'll progress to the central resection, to the motor resection. And this is the SEG, the recordings that we obtain in the OR, completely arrest of the epileptic form activity. Just for you to comparison, this is the pre-resection. This is the post-resection in the OR. Very clean with a relatively small resection. This is post-op MRI. And you can see here the small resection that we obtained. Again, I just wanted to remember you, this is a known lesional Rolandic epilepsy, difficult case in a 3-year-old. The mom didn't notice any motor deficits. He likes to play with Star Wars, so really no deficits at all. Of course, the age helps, but I think he has a very, very good recovery out of this procedure. He's completely seizure-free, and pathology review cortical dysplasia type 1. So I think this case illustrates clearly how you can manage difficult cases with DEPS electrode, but also how we as surgeons, we can use all the armamentarium necessary in order to approach those difficult cases, and sometimes make a combination of different approaches using extraoperative but also intraoperative mapping in order to really define the areas that we need to resect and with minimal morbidity. We have a series of those SEG intraop recordings. This is another case with cortical dysplasia, which was resected, doing so very well, and also another premotor areas also with the same technique. So I believe it's 8:40 in Sao Paulo. I would like to finalize so we can have some room for questions. So as conclusions, I would like to emphasize that invasive monitoring with precise functional mapping is commonly required in Rolandic epilepsy. I would also like to emphasize that optimal results can be obtained with combination of approaches. And many times, I think we should think about those cases as challenging cases, but cases that can be also very rewarding if we perform and we understand the seizures and we perform precise mapping. And of course, we should always consider neuromodulation if the risks of the operation overcast the benefits of the operation. So again, this is my last slide. I would like to thank you, the society, for this kind of invitation, and I would like to have any questions. Thank you so much.
Thank you, Professor Jorge Martinez. It was very elegant, really elegant class. Thank you very much. I'm very impressive. Well, now I would like to invite Professor Antonio Almeida and the moderators for questions and comments. To start, Professor Almeida, would like to start the comments and questions, please?
Okay, I will start with my first comment. Actually, it's a very interesting technique. The SEG, I think, brings a lot of information that the GRIDS does not. But I would like to ask you, did you ever perform laser ablation of these lesions? Because you put the electrode over there and it's small lesion, so can you just burn the lesion with laser or thermocoagulation?
Yeah, that's a good point, Antonio. I think it's definitely possible. My concern about doing laser ablation is there are two concerns. Number one, the patient in general is in general anesthesia, and I don't have a good clinical feedback while we're doing the resection. I don't have any electrophysiological feedback. The second concern that I have is that I don't know how to define the extent of resection when I do the laser ablation, because I need to, because of MRI safety, to remove the SEG electrodes. So even if it's a small resection, I would prefer to do this the way I just presented, with electrodes in place so I can have electrophysiological feedback. However, I think another very good option to laser ablation that I would consider in those cases is the thermocoagulation. I think for small lesions, perhaps thermocoagulation in those areas with the patient awake, with the preservation of the SEG electrodes is an option. Of course, the ablations they cause, they are small and probably less in terms of volume of treatment, less than what we need for those patients to become seizure-free. But I have to consider that it's a much more interesting option and much more viable option, even economically option, to perform thermocoagulation in those areas because of the clinical feedback and because also the electrophysiological feedback that we don't have with the laser.
Pretty interesting.
Thank you. I would like to invite Professor Stenio. Professor Stenio Sarmento, please.
Thank you for the invitation to be here. It's very impressive. In this time of difficult time, we are always interested in learning neurosurgery and epilepsy surgery. I have congratulations for the lecture, Jorge. You are always didactic, and we learn very much with you. I have three questions. The first one is about the which case do you prefer only to use depth electrodes or grid, subdural grid? There is a case that you never use in this Rolandic cortex, never use depth electrodes. This is the first question. The second one is about how long after the invasive investigation you perform the surgery. And the third question is about when you have patients that was underwent glioma of the supplementary area and a resection, a complete resection, and this patient evolved with persistent focal motor seizures, intractable with medication. So in this case, do you prefer put depth electrodes or subdural grids or other option? And I think there is another question. I'm sorry. Do you use in which case do you use or never use a subpile transaction in this case?
Okay, so I will answer backwards. So I remember, and perhaps I forgot the first one. So subpile transaction, I will never use subpile transaction. In my experience, it does not work. What I accomplish with subpile transaction is neurological deficits with seizure outcomes. So the double loser with no seizure improvement. So I don't use subpile transaction. In the case of the glioma resection that continues to have motor seizures, perhaps this glioma is associated with pathology surrounding the glioma, perhaps invading the motor areas, perhaps invading the sensory areas, perhaps involving the motor cingulate. I don't know. I would implant this patient with electrodes to really understand from where the seizures are coming from in general. Your question about using subduros, what are the cases that I use subduros and what are the cases that I don't use subduros? I have to confess, I don't remember the last time I implanted a subdural grid. It's been a long time ago. I think it's a valid approach, and I would not discourage anybody to not do the subdural. I would not discourage anybody to manage those cases with intraoperative mapping, which is also a very good option and also a very reasonable option with very good outcomes. It all depends on your experience and the experience from your group in managing those patients with this or that technology. I am very, very comfortable with mapping with SEG electrodes. My group is comfortable, but in many times subduros will work as great. What I think we need to have in mind is the limitations that we have, and every method has limitations. And we need to understand the limitations in order to really choose the right technique. So the Suduro will not be able to record anything from the depths, and most likely will show a very broad distribution of the epileptogenic zone in an area that is more deep located. So we need to understand that every time we use Suduros. The SEG will provide perhaps less definition at the surface than the Suduros. So if you have a superficial lesion, perhaps this will be challenging to map with Suduros, and perhaps this could be done with Suduro electrodes and not with SEG electrodes. The extraoperative it's an excellent method. However, it requires a good team of anesthesiologists. It's more challenging in pediatric patients. I think it would be difficult to obtain very precise mapping in pediatric patients with extraoperative or intraoperative mapping. It's possible, but again, it depends on the experience of your group. So, and as I illustrate, nothing wrong, or probably will be beneficial for the combination of those different methods. As you can see, we did the SEG, we kind of define our surgical plan, and we went to stage 2 where we use intraoperative mapping to really help in defining the extent of resection. So I think you can use a combination of procedures as well. Did I answer all your questions, Steny?
Yes,
Yeah.
just one has left. It's about the how long after you conclude the invasive investigation you perform the surgery.
Yeah. So for those cases, Rolandic, I perform right away. You can see that I did the mapping. I took the patient right away to the operating room, and the reason why I did that is because of the craniotomy is outside the entry point of the electrodes. So if we need to do a craniotomy just at the entry point, I prefer to remove the electrodes and then bring the patient after 4, 5, 6 weeks for the resection.
Thank you.
So, Daniel, can I?
Yeah,
I would like to apologize because I believe Dr. Antonio Almeida have another question or comment, and I'm preparing the questions and I don't see the video. Antonio?
Actually, go on. Maybe Dr. Paglioli or Dr. Machado, they just everybody. I'll make it in question at the end if you had time.
Okay. Professor Eliseu Paglioli, please. Do you have any comments and questions?
Okay, yes. Are you hearing? Okay. Jorge, congratulations. Always excellent presentation. I have a different approach. We used to do intraoperative in dysplasias, of course. I'm talking about dysplasias. But my question is, have you ever seen ictal onset zone outside an interictal continuous epileptogenic zone? Let me say in other way. In our cases, always the interictal in dysplasias, they mimic the ictal. We don't need to wait an ictal because always the ictal comes from the interictal. So I asked this question to Imad and to others. And have you ever seen an ictal activity outside an interictal in the opposite direction?
Right. So again, I think this is a very interesting question, and I think you raise a very good point. So for example, that case that I just showed, the 3 years old, that's what you're saying. The ictal recordings is the interictal recordings is very similar to the ictal recordings, but this was a very unique case because this was epilepsy partialis continua. So that, again, to perform this, what I just showed to you, there is a selection that I didn't mention, a proper selection of patients where we believe the interictal is very close from the ictal. And that's what you were mentioning. This is probably much more true when you have a type 2 dysplasia. When you have a type 1 dysplasia, it's a different thing. It's a completely different organization. I think you agree with that. So I agree with that, with your comment when you're talking about the type 2 dysplasia. And the challenge here is when you have non-lesional type 2 dysplasias, which are rare, but they occur, and we don't know a priori if this is the case. And I agree with you, many times we found a very diffuse activity, which concerns us in terms of seizure outcome. But I think your point is very well taken. But I think this is more true when you have a type 2 dysplasia, when you have a lesion on MRI, when you see a lesion. And I agree with you, those cases, they do very well with intra-op monitoring, intra-op mapping like you do, and you so well.
Yeah. Because when as the ictal is very fast propagation, has very fast propagation, mostly in those cases, the interictal mimics more the epileptogenic zone. Because the interictal clinically, because I may consider the ictal activity, electrographic activity as ictal, because they are continuous. Okay, it's semantics. Okay, yeah. But you are right, when type 1, they are most difficult cases, because we never know if you resect, if you have other areas that may come epileptogenic amounts or a day or 5 years later. So type 1, they are the most challenging cases in children, in my opinion, because it's very difficult to understand. We have many cases that they remain seizure-free for 5, 6 years, and then they start again. After a second hit, like I show you a case that a man hurt the hand, and this trigger an epilepsia partialis continuous in the sensory, but clinically in the hand, in the motor area. Yeah. But it was exact like your case, but it was a man 48 years old. So thank you for your comments, Jorge, and I hope to see you in your new hospital when the pandemic is over next year.
Thank you, Elisa.
Well, Professor Hélio Rubem Machado.
Thank you, Paulo. Thank you very much. Thank you, Jorge, for your excellent talk. And we all know that in this time, you are a very known person to have reintroduced this old technique in the world, not only in the United States, but everywhere. And you are responsible for that, and we are very proud of that. And I'm very happy also because you showed cases of children. You know that this is what I like to do. That's my specialty. And talking about children is totally different when you talk about surgery in eloquent areas comparing with the adults. You have not only, you know, that motor eloquent cortex, but also language cortex. And we are always concerned in children, mainly cases with the Rasmussen in the left hemisphere. We are always concerned with that problem. The other thing is, and the question that I want to make this moment, that we are dealing with a malformed eloquent cortex. We're not operating on a normal cortex, normal motor cortex. So that's the reason why we can go further in children. We can resect very close to the eloquent areas, motor areas, as you showed, and sometimes inside the motor cortex. And probably the area is relocated anteriorly or posteriorly. You see only mild deficit and not permanent deficit frequently in children. I think the main concern for us is not surgery, it's the neurologists. Do they accept to do this kind of surgeries? The question I want to make is how far can you go? What is your limit when you see a case like that? You don't know whether you will have a permanent deficit or not. And how do you talk with your parents? You show that, but with the neurologists to accept the risk to have a partial deficit sometimes. Thank you very much.
Thank you. I think it's a very interesting question, Elio, and I think you just hit the core of this problem with pediatric epilepsy. To me, and I'm sure you agree, epilepsy is a devastating disease with great consequences lifelong. And the opportunity to treat those kids, the sooner as possible, will change their life and will prevent all the comorbidities related to epilepsy. When you have a patient with an adult epilepsy, you treat the seizures, but many times there are social impairments that cannot be treated anymore. Depression is in place, alcoholism is in place, low education is in place, and the damage is sometimes irreversible, even if you can treat. Pediatric patients, you can completely, if you stop their seizures, they will have a normal life. I tend to be more aggressive in pediatric epilepsy than I do in my adult cases. I think I would like to be more aggressive because of the impact of the epilepsy surgery in those cases will be higher compared to adults. And number two is because the possibility of plasticity in those kids. They will become with deficits, but they partially recover. And I think I will tend to have a very clear, informed consent, but I have to confess, I always like to be more aggressive. And of course, it depends on the seizure burden. It depends on a lot of factors. For this case that I just mentioned to you, I consent this kid with the family for a full deficit, for a full neurological deficit. And the family said, go ahead. If you can preserve some function, that'll be great. But if this is what you need to do in order for my kid to be seizure-free, just do it. I think to have the chance for a double loser, we try to do a less aggressive operation in the Rolandic areas. And we don't stop the seizures, but also we cause a deficit that is devastating for the family. We make this kid worse than he was. So I tend to be more aggressive in general and consent, of course, the patients for the high probability of a deficit. That's really my approach. And if they are not ready, they're not ready. That's the way I manage my practice.
Okay, now we still have a little time for questions. Would any of the panelists like to ask or comment?
Yes,
anyone?
Just a very short question. How long it takes to implant a patient with SEEG in your department?
The implantation, the procedure itself?
Yep.
How
long it takes? The surgical procedure?
Yeah, so the registration with the robot takes me 20 minutes. And the incision time to the end time is approximately 1 hour and 50 minutes. Yeah.
Wow, it takes 2 hours. You do the entire work.
That's right. It's a 2-hour procedure. That is correct. Yeah.
Amazing.
Yeah.
We have a question from Carlos Benedetti, and it's open to all the panelists. And what kind of mapping technology do you prefer for extensive cortical dysplasia? SEEG, grids, strips? What do you usually do?
I normally do SEG. I normally use SEG as a mapping. I many times use the combination as I showed before. But SEG is the method that I'm most used to. Again, there is no validation. There is no comparison. There is no study that shows that one is better than the other. I don't think there will be ever a study that will compare. And by the way, there are no studies that shows that invasive monitoring makes any difference for patients. in terms of seizure freedom and seizure outcomes. So again, this is all very, it's a personal, more anecdotal personal experience that we have. Yeah.
And what is the opinion of Paglioli, Machado, Dr. Machado? And extensive lesions over the cortex, what do you think is the best way to monitor cortical dysplasia?
Well, we have typically used grids and strips for a long time because of the peculiarities of children. But in the last years, we have moved to SEEG, and we are very happy with that. The reason is what Jorge said, that the size of the first surgery to implant the grids, and probably the quality of the surgery that we have reduced it with time. We have reduced the size of the resections. And the problem for our country, everybody knows, is the cost of this. With this pandemic, I don't know, I cannot say when we come back if we will do SEEG again. But my idea now is SEEG is the best option for children.
Yes, we are here in Porto Alegre, we always use in the last 30 years intraoperative with the Aranha like Montreal, using the new techniques in the MRI and intraoperative monitoring of the motor area. So I think it's good for children older than 2 years old. Younger than 2 years, it's difficult to place the device because the bone is so thin. So it's difficult. It's better to use grids. But I prefer to use we call the Aranha device like Montreal, because it permits to check after the resection if there's any activity, electrographic activity after the resection. So for me, this stepwise resection, checking the EEG, the ECOG, is fundamental to resect dysplasias. Not for always tumors or for vascular destructive lesions we don't use. We only use for dysplasias the ECOG, pre and post, and many times 3 times. A pre, then a resection, then a confirmation that everything is clear, and then more resection if there's some areas that becomes epileptogenic after the resection. And then I'm happy with this. It's very inexpensive because you may reuse the device. We are producing in this year, next year probably, a disposable support, and the electrodes we can reuse them because they are gold plated. There's no problem. And so the support is disposable. So we are happy.
Daniel?
Yes,
Want to make a comment?
Here in João Pessoa, we have used only a subdural grid, but over time we have discovered that there are some limitations in terms of networks, in terms of a comprehensive network in patients with exotemporal lobe epilepsy. Probably soon we will start to use SEEG. Jorge, what about DTI and MRI, functional MRI to guide you about the calculated deficit in the patient? Do you use it?
I don't think it's necessarily a bad idea. Actually, it's interesting idea. I tend to, again, I think the location of, in general, for 90% of my cases, the location of the motor and the sensory are so well defined, and based on the topography, based on the distance from the ACPC, as I mentioned to you, as I showed to you, that I don't need a DTI to show me where the motor, motor and the sensory areas are located. But in large cortical dysplasias with a lot of anatomical distortion, I think it's a valid method, and I will probably do those DTIs in those cases where the anatomy is not so well defined that we really don't know where the motor and the sensory are located. For example, in schizoencephaly, when you have those clefts in large cortical dysplasias, very difficult sometimes to really define what is the motor, what is the sensory, and I think DTI it's a reasonable approach.
I'd like to open a question of the Dr. Cukier to everybody is which neuromodulation technique would you suggest to treat the Rolandic epilepsy?
So Artur raised a very interesting question. We are handicapped in the United States because of some limitations about utilization of neuromodulation for epilepsy. So what is available here and FDA approved is the RNS, the responsive neurostimulation. And in general, when you have Rolandic epilepsy where you localize the epileptogenic areas, but you cannot, we know exactly the areas, but you cannot resect because you are concerned about deficits, or the patient that does not want to have any risk for a deficit. RNS, responsive neurostimulation, is the option that we have. I have the second option for DBS, for anterior nucleus. I don't think that is the indication for Rolandic epilepsy. I think anterior nucleus is more for limbic epilepsy because of the circuits that we're stimulating. Although it's approved for focal epilepsy without any specifications, but I don't like to use this type of DBS implantation for Rolandic. So pretty much we have only the RNS option for those patients. And of course, I forgot to mention, there will be always the option of vagal nerve stimulator, which is not my preferred method.
And even in Rolandic area, do you use the VNS? Because
I don't use at all VNS, but
okay.
it's labeled as treatment for focal epilepsy. Is not labeled for generalized epilepsy, which is I believe is the main indication for. It's in the US, it's used as an off-label. And I have to confess, many of my colleagues from neurology, they refer patients to me for VNS for Rolandic epilepsy. And again, it's not my my prefer, and I would not do those procedures, but many of our colleagues, they do VNS for Rolandic epilepsy. Yeah.
And do you have any experience with a central median nucleus stimulation?
Yep. So we do central median nucleus stimulation, not for Rolandic epilepsy, but for generalized epilepsy, mainly for patients with Lennox-Gastaut. Again, it's an off-label use. You need some approval, but this is the main, not for Rolandic epilepsy.
Okay, the other panelists have any opinion about the neuromodulation? Pagliori, Machado?
Part of VNS, I don't think, I agree with the Jorge. I don't think that in children, there's any place for other neuromodulation. In this case, we tend always to try to do any kind of surgery. Yeah. I think is the best.
Okay.
Paulo, do you want to make any question?
Right. Okay, we have some questions from audience. Okay, I select some. Since surgery on awake children is difficult, what method do you use to identify language in areas in children? Dr. Jorge.
Yeah. Again, those are challenging cases. When you operate in near language areas, again, we are a little bit out of our Rolandic epilepsy topic. Those are difficult, very difficult cases. In small kids, you can do some intra-op mapping with the motor system. There is no requirement for patient's collaboration many times with somatosensory evoked potential. But for language, it's challenging. And it depends on the age and depends on the areas that we're operating. In general, if you are concerned about posterior language areas, we normally perform this with SEG electrodes in those areas, many times with pseudodural implantations also, especially for the posterior language areas. Again, those are very difficult cases. If it's truly a small child, we need also to remember that there is a huge plasticity, mainly in language. And even if we're talking about less than 5, 6 years old with preserved speech, with seizures coming from that location, frontal operculum, posterior temporal areas, I will resect. I will go ahead and perform without mapping. I know this kid will have a deficit, but I know also that he's going to have a complete recovery from those. So it depends on the age. When you're talking about kids of more than 12 years old, more than 10 years old, then it becomes much more challenged because we don't know how much plasticity they will have, and most likely a permanent deficit will occur. But if we're talking about small child, we're talking about less than 5, less than 6, I think you can perform the resections that you need without the speech mapping. They will have a deficit, but they will recover.
The next is a comment and question. Repeated lesionectomies using intraoperative MRI may be clinical beneficial in patients with Rolandic intractable epilepsy.
Yeah, intraoperative MRI is it's a nice tool. It gives some reassuring that you resect the areas that you're thinking. I think if you have a good anatomical knowledge and you have guidance of electrophysiology, I don't think it's a procedure that is required. I don't use intraop MRI in my cases.
Intraoperative ultrasound allows for more tailored resection by facilitating the delineation of the dysplasic tissue with resolution superior to MRI of all focal cortical dysplasia types. Is for your comments.
Yeah.
Intraoperative ultrasound is better than MRI, intraoperative MRI for focal cortical dysplasia.
Yeah. So
what's your comments?
Again, Paulo, I think an important notion that we need to have here is that we do epilepsy surgery and we are not lesional surgeons. So I'm not much interested in the complete resection of the lesion that I see on the MRI, but more importantly on the resection of the epileptogenic zone that is guided by electrophysiology. So that's perhaps the bias that I have to myself, that I don't rely on methods to better localize and to perform a complete resection. We're not talking about tumoral surgery, we're talking about epilepsy surgery. And I think there is a fundamental difference in those types of operations. So that's my personal bias. That's why I don't value too much the very sophisticated methods of trying to resect the entire lesion. I will value much more the intra-op electrophysiology or the extra-op electrophysiology. This is what I think it's important to obtain better results.
It's about Rolandic epilepsy, of course. What predictive clinical and neurophysiological factors did you find associated with the better seizure outcome? So
I think Eliseo briefly mentioned about when you're talking about lesional epilepsy, which is supposed to be cortical dysplasia type 2, where the interictal recordings are very similar to the ictal recordings when you have a very clear localization of the epileptogenic zone. Those are, in my opinion, the best cases. The bad cases are the semi-lesional. They're the lesions that are very unclear, or the non-lesional cases. Those are the very difficult cases that are not associated with better procedural outcome. And again, this is not specific from Rolandic epilepsy. This is related to epilepsy in every area, every lobe or location in the human brain.
Of course.
And Paulo, I just want to complement what Jorge said. When we talk about Rolandic, it's a very broad term. The Rolandic may be the motor, strip, and the sensory, and the motor, the upper portion, the cranial portion, and the lower portion. So when the challenge is the upper motor area, not everything in the Rolandic area is untouchable. Okay, so it's very, there are limited cases that occur exactly on the hand and leg and foot area. Okay, so not all cases that we call Rolandic are untouchable. Okay, so we must define the Rolandic area, the upper portion that is indispensable for a good quality of life. But the lower portion for the tongue, face area, and the sensory, you may resect. It's Rolandic, but so it's not good to pull together all the cases. So you inflate your good results if you put in the Rolandic areas surgery in the sensory and parietal or premotor areas. Okay, so I consider Rolandic the motor from the hand to the cranial area.
I think this is a very important point, Eliseo. Thank you. So that's absolutely right. Surgery from face, motor face sensory area on the perisylvian Rolandic areas are completely different than the leg motor sensory, hand motor sensory areas. It's a completely different operation. Yep.
We have some questions about the. I'm sorry. Any comments about this?
Yes, Paulo. Yes, please. Jorge, considering that Paglioli has said, in patients that you conclude after invasive monitoring, you conclude that the focus, the epileptic zone, is in the hand area. Do you resect after consent of the family, or you never resect?
So again, it depends on the age, depends on the seizure burden. Every patient it's different. Again, if there is a very clear correlation, very clear correlation, this is a typical hand motor primary lesion in the hand motor with good functionality. This patient will have a deficit. If he wants to become seizure-free, he will have a deficit. And I will not operate those cases if the patients want to guarantee that no deficit will happen. I think there is no, this will be a false hope. So I will say right away, you're not a surgical or resective surgical candidate for resection. We can do neuromodulation, other things, but not for resection. Now, if the patient is willing to face a motor deficit, that's the case that I will attempt to perform an operation and define the intractability criteria as an intra-op intractability criteria. So we try to, we operate, we open, we try to resect. There is a clear deficit. We confirm this is something that cannot be resected. So I would tend to be a little more aggressive, again, depending on the age, depending on the seizure burden. But many times the concept of intractability, it's an intra-op concept. And again, this needs to be very well defined. And again, this is the difficulties of Rolandic epilepsy of those cases. It's just the risks are so close on the benefits, and the chance for a double loser, that's what you're trying to avoid, it's high. So this all needs to be discussed.
Thank you.
Can I make a comment?
Please.
Well, there is, as I mentioned, we cannot compare children with adults. As I mentioned, you're not dealing with a normal cortex. You're dealing with malformed cortex. There's aberrant a network. And so it's, I think, consider a priori a case inoperable. It's very hard, very difficult in children. And there is another thing that's very important, and George mentioned that, is plasticity. We always, after surgery, we always work with this plasticity in rehabilitating these children, and they respond very, very well. So that's the point that I mentioned when I mentioned that sometimes it's difficult to talk to neurologists because they compare with the adults. If you operate on the hand area that's lost, you never move the hand again. No, you're dealing with children. And as Jorge mentioned, under 10 years of age, even language, we go much further. We are much more aggressive comparing with the adults. Thank you.
Any question? We have some questions about the, again, lateralization of the language with functional MRI, tractography, or VADA test. If you have opinion of anyone, Jorge.
VADA test is something, no way, you never use it.
No way?
We use fMRI in general. We have a protocol for language lateralization with MEG as well, which is interesting, but again, not well validated. So perhaps our preferred method is fMRI. We don't discard completely the WADA test. I think there are still a role for WADA test in very specific patients when there is a dubious information from the fMRI, and in very difficult cases, yes, sometimes, but it's very rare nowadays.
And Paglioli, Machado, WADA test, do you have any opinion about nowadays?
Yeah, we use, but maybe 2 or 3 cases a year only, because fMRI solves most of the cases. And you may see DTI, the extension of the fasciculus also, you may observe, and clinically if it's important or not. But in children, like Elio Machado just talked, I don't think it's necessary to be so worried about language in younger children. In adults, it's different.
Yeah, we don't use WADA test in children. We rely on fMRI, and the question with language is we consider language up to the 10 years or even sometimes 12 years of age before doing surgery. And remember, it's not rare to see children with bilateral areas during the process of the disease, mainly with Rasmussen encephalitis. You see the left, for instance, a left side language, and this, as the disease progresses, has become bilateral. And we do surgery, we resect, we do hemispherotomy, and the children do not have any language deficit in the post-op. So it's very different to consider a language considering children and adults again.
Mm-hmm.
Any panelists?
Want to make any comments? And
someone? All right. Antonio, if you agree, I would like to thank you very much, Jorge. Thank you very much, Eliseu, Dr. Elio, Dr. Stênio, and now our president. To conclusion, Dr. Antonio Almeida, to finish our webinar.
It's just to say goodbye to everybody and thank you all. It was a great discussion, great presentation, George. It's really good to have you here. And I hope everybody's good, in good shape and good health. And in the near future, I hope to meet everybody in person, not just on the television. Okay.
Yeah.
Thank you all.
Thank you.
Bye-bye.
Thank you. Bye-bye. Thank you very much.
Jorge, keep in